screen can unmute or drop in the chat box. Sawa, thanks. So this presentation is really short. I know you guys have probably had a long day and I don't want to keep you. So let's just start. Acute kidney injury. From the name, already this suggests an acute process. So that's something that happens very quickly, very rapidly. And again, from the name, it affects the kidneys. So let's see the definition. Okay, so acute kidney injury is different from acute kidney disease and is also different from chronic kidney disease. AKI, which is the scope of this presentation, is an abnormality in the function. Please note the word function, it's even been highlighted over here. It's an abnormality in the function for a period of 6 hours to 7 days. It's a very acute process, limited to a week up to 7 days. Acute kidney disease, on the other hand, is an abnormality in the structure and function. So while the injury is only about the function of the kidney, the disease is concerned with both the structure and the function. What this means is that in AKA, the kidneys will be filtering out, won't be able to filter out things like creatine. So you'll have a lot of creatine buildup in your serum. While in the structure, it means that things like the glomerulus and maybe even the capillaries have been interfered with. And this interference allows passage of big molecules like proteins. And that's how you get protein in your urine, albuminuria. I hope that makes sense. Another difference is that acute kidney disease is limited to a period of less than 3 months, while again, AKI is only up to a week. CKD, I think this one we all know, is the one we mostly see in the ward, and it's an abnormality in the structure and function for more than 3 months. So the only difference between AKD and CKD is the duration. Acute for less than 3 months and CKD for more than 3 months. It's important to note that a patient with CKD can have superimposed AKD. I hope that makes sense. In that, say a patient who's been having long-standing CKD, they've been on dialysis for a long time, and say maybe this patient is also hypertensive or diabetic, meaning the immune system is already suppressed. They can have an infection of their kidneys, of their glomeruli, to be specific, glomerulonephritis. And this superimposed infection would be termed as an acute disease or injury superimposed on CKD. Also, you can ask questions as we move along. Please feel free. So this is what I was saying. AKI, the injury, is an abnormality in the function only function in injury. But for the diseases, that is acute kidney disease and chronic kidney disease, there's a dysfunction in both the function and the structure. So for the structure, again, we can see here, if you want to assess, if you're querying, is this acute kidney injury, is this acute kidney disease, you can differentiate from the markers of kidney damage, which are albuminuria, hematuria, and pyuria. These ones you can see when you do your urinalysis. And again, we've said it signifies the structural abnormality because it means the glomerulus has been interfered with and there's passage of these macromolecules. For the functional criteria, as you can see here, it's defined by things like serum creatinine, urine output. Here we have oliguria, things like your glomerular filtration rate. We'll see more in the next slides. But yeah, so the second column, let me say, is AKI. Then we have AKD, CKD, and this last one that says NKD is no kidney disease. So this is ideally a healthy patient. Their glomerular filtration rate will be above 60, and they'll have no marker of structural kidney damage. So again, AKI here has 3 different stages. They are better defined according to the serum creatinine and level of urine output, which is oliguria, anuria, whichever, depending on the amount. So for AKI, these are the 3 stages. I don't think you have to know these numbers. I'm pretty sure you don't. I think the most important takeaway from this slide is that AKI is staged according to serum creatine levels and the urine output. So you can see here, if a patient has not passed urine for more than 12 hours, that is anuria for 12 hours, they're already AKI stage 3. So just to repeat what we've said, these are the markers of kidney damage. Kidney damage is broken down into structural damage and functional damage. So when you want to assess functional damage, which is for AKI, AKD, and CKD, you can look at the serum creatinine. You can look at glomerular filtration rate. You can look at cystatin C. Cystatin C is let me say, a product that is produced by nucleated cells. And it's normally filtered by the kidneys, but now if there's a abnormality in the function, it won't be filtered out and it will accumulate in the blood, resulting in high levels. Sometimes actually cystatin C is preferred over serum creatinine because, unlike creatinine, cystatin is not dependent on things like the mass of your muscle and your body habitus. But also now that is not to mean that it is perfect. Another is because the reason you don't see it a lot is because it's expensive and is affected by thyroid disease. The last marker of kidney dysfunction would be urine output. As we've seen, things like anuria and oliguria are used to classify the stage of AKI. For structural markers, here we're thinking, what would say that the glomerulus has broken down? What would mean that the tubules have increased permeability? Things like that. So we're looking at albumin in urine, blood in urine, pus, white blood cells in urine, the urine sediment casts, imaging abnormalities. If you do an ultrasound, you would see small kidneys. Normal kidney size is like 11 to 15 centimeters. But sometimes when there's a lot of fibrosis and stuff, the kidneys become really tiny, below 11 centimeters. Also on imaging, you'd be able to see something like cysts in a patient who would have like polycystic kidney disease. And all this will just point you towards structural abnormalities. Lastly, on histologic changes, when you take, say, a biopsy and take it to a pathologist, they will see fibrosis in the microscope and things like that. So remember, structure are the diseases, acute kidney disease and chronic kidney disease, while AKI is only kidney function abnormality. Okay, this was just to see that if a patient has less than 60 in the glomerular filtration rate, which is among the criteria for AKI and CKD, already they'll be at stage 2, as you can see here, 60 to 89. It's important to know this table. You can be asked in your long case to stage CKD according to KDIGO guidelines. Okay. So acute kidney disease without the injury is associated with high mortality and faster CKD progression. What this means is if there's only structural abnormality, there's a very high chance that the patient won't make it. And there's also a higher chance that they will progress to chronic kidney disease quicker. So in patients like this who have structural abnormalities, they may require renal replacement therapy. But it's important to note that most AKI is reversible and caused by a lot of factors. So to treat it, you have to treat what is the cause. So on the causes, there are pre-renal causes, renal causes, and post-renal. It's always important to classify them this way whenever you're asked, because consultants just like to see that you can think logically. So pre-renal is everything before the kidney, mostly decreased perfusion. So why would there not be enough blood getting to the kidneys? In cases of heart failure, where the heart is not pumping enough blood to get to the kidneys. If there's GIT loss, this means excessive vomiting, excessive diarrhea. There's decreased volume of circulation in your body, meaning there'll also be decreased blood getting to your kidneys. When there's skin loss, say through burns, your level of fluid in the body decreases. When there's cirrhosis because when the liver is going through all these things, there is splanchnic vasodilation, and a lot of blood tends to accumulate where the capillaries and veins and arteries are vasodilated. So there'll be decreased perfusion of blood to the kidneys. In shock can be septic shock. Shock can be hypovolemic shock, where you've lost a lot of blood. There can also be vascular occlusion. Please note that the vascular occlusion does not include the vessels in the kidneys. All these are pre-renal vessels. And lastly, third spacing. Third spacing is when you have a lot of movement of fluids from your capillaries into the interstitial space. So this is when edema happens, and it's a cause of decreased perfusion to the kidneys. On renal causes, think everything that happens in the kidneys. There's a diagram of a nephron here, just to help you picture everything that could possibly go wrong. In the tubules, you can have acute tubular necrosis. In the glomeruli, you can have infection. You can have a problem with your microvasculature. You can have infection in the interstitium. Your large renal vessels can become thrombosed. There can be obstruction within the nephron. And in patients with a transplant, there can be allograft rejection. So for renal causes, really just think everything that could possibly go wrong in the nephron. And the last cause of AKI is postrenal causes, things that happen after the kidney, on the way from the kidney to the urethra. So you can have bladder tumors, there can be parasitic infections as in schistosomiasis, you can have retroperitoneal fibrosis, calcifications, a stricture in your urethra, your bladder can be obstructed, anything that now happens in the urinary tract. So clinical presentation of AKI, remembering that it's a dysfunction in the kidney, there'll be retention of nitrogenous wastes. So a patient may have uremic symptoms. Uremic symptoms vary a lot. There can be uremic encephalopathy, things like a patient feeling dizzy, feeling confused, headaches. Uremia can manifest in the GIT, where you have a lot of nausea, vomiting, and diarrhea. Uremia can manifest in your heart, where you have pericarditis. It can manifest in your skin. You will be itching a lot. Where else can it manifest? It can also cause coagulopathies and bleeding disturbances. Dysfunction in the kidney would also cause electrolyte imbalance, remembering that the kidney is associated in acid-base balance. So a patient will have hyperkalemia, so think arrhythmias. A patient may have hypernatremia. When there's hypernatremia, the blood vessels can tense up, and when you're taking your BP for your clinical exam, you find that a patient has hypertension. With hypernatremia also, water always follows the reabsorption of sodium. So there can be edema and pulmonary edema as well, not just in your feet and distal tissues. Acid-base disturbance may also be another clinical presentation. So think metabolic acidosis. There'll be a lot of hyperventilation as the patient is trying to get rid of this acid. And another presentation is decreased urine output. There's decreased perfusion to the kidneys. So again, so there's decreased urine. Investigations, you can do lab investigations. These are the most important. In your CBCs, you're checking the level of white blood cells. Maybe there was an infection as the cause of the AKI. You can also do your UECs. You're checking the creatinine level, of course, to stage the AKI. Electrolytes to check whether there's hyperkalemia, whether there's hypernatremia. And in a patient with uremia, the urea will also be increased. We talked about cystatin. It's another important marker of kidney function. If it's elevated, it means there's bigger damage. In a urinalysis, you will see things like protein, things like blood or white blood cells, and blood gas analysis may be deranged if the patient has metabolic acidosis. On imaging, which is not really necessary at all, it's just to rule out the structural abnormality. So if you do an ultrasound, you will see that there's preserved renal size. Remember, if there was a dysfunction in the structure, which would indicate acute kidney disease, the kidneys would be smaller. And chest X-ray you can also do just to rule out pulmonary edema as a complication because there's third spacing of fluids. On management, remember that AKI is very reversible. So you are just trying to undo the causes. The first step would be to stop all nephrotoxic drugs. Nephrotoxic drugs include things like contrast media, ACE inhibitors, NSAIDs, which are very common, diuretics, and ARBs. This list is not exhaustive. You also have things like lithium, say maybe in a patient with psychiatric disorders, and vancomycin that are also nephrotoxic. The second line in management would be to treat the emergency. What has the patient come to you with? Have they come because they are vomiting a lot because of the uremia? Have they come when they're hyperventilating? Have they maybe come in a cardiac arrest because of hyperkalemia? Treat the emergency next. and then manage the cause. So in the cause, again, you have to think, is it pre-renal, renal, or post-renal? The next step would be to establish euvolemia. If a patient had AKI because they were involved in a fire accident and they bled a lot, you need to perfuse this patient with fluids. And while perfusing the patient with fluids, also think of electrolytes. If they have lost electrolytes, you need to replenish them. And the last step in management would be infection prevention. So is this a patient who needs prophylactic antibiotics? Is this a patient who will be admitted for a long time and would maybe need heparin to prevent a DVT from occurring? Things like that. Okay, I think this is my last slide, and then we'll see if anyone has any questions, and then we do like one question together. So the outcomes for an AKI, we've said it's very reversible, but sometimes a patient will have a poor prognosis if they've had oliguria, if they are above 70 years, if they've had a background of CKD. Remember what that means. If they've had associated serious medical conditions or multi-organ failure. Patients with AKI may pass away if they are of old age, above 70 years, if they have had previous chronic illness, infections, congestive heart failure, if they've been admitted in ICU or are currently admitted, if they have multi-organ failure, and if they need renal replacement therapy. So that is it about AKI. I think it's pretty straightforward. Does anyone have a question? If not, we'll do one question together that comes in the form of an MCQ. So questions? Sawa. Oh, wait. Oh, thanks. Okay, no problem. Welcome. So let's do one question, and I wouldn't be the one to answer it. You guys will answer. Okay, I think we can all see. A 20-year-old woman is brought to the emergency department because of severe muscle soreness, nausea, and darkened urine for 2 days. The patient is on the college track team and has been training intensively for an upcoming event. 1 month ago, she had a UTI and was treated with nitrofurantoin. She appears healthy. Her temperature is 37 degrees Celsius, pulse is 64 per minute, blood pressure is 110/70, and cardiopulmonary examination shows no abnormalities. The abdomen is soft and untender, and there is diffuse muscle tenderness over the arms, legs, and back. For lab studies, hemoglobin is within range, leukocytes are normal, platelet count is normal. I really couldn't tell you about the serums. I'm not sure. Maybe someone can be checking on that. But for the urinalysis, there are some abnormalities. There is blood and there is protein in the urine. So the patient is at greatest risk for which of the following complications? Let me find a way to minimize this, so you can see the choices. Hoping it doesn't get too small. Okay, someone to unmute or type on the chat box what they think is the complication. A, acute kidney injury. Yeah. the patient is at risk for developing acute kidney injury. Okay, so if you guys have AMBOS,